Thank you. So we've got Mr. Scott Robbie here today. He's a consultant from St Thomas's, corneal surgeon and anterior seg consultant. We're very lucky to have him. He's done a lot of work on cornea and specialised in complex cases. So I'm going to hand over to him now. Thank you, Mr. Robbie.
Okay, thank you, Bhavina. Good evening, everyone. I'll move swiftly on because this is quite a chunky talk. I should say that at the outset. So Bhavina's going to put the brakes on me in about half an hour, 45 minutes, so that she can crack through her cases. The cases she's going to talk about are quite dry eye, sort of heavy. At least that's the flavour I'm getting. Bit of keratoconus thrown in there. So very much the meat and potatoes are what you might see in your practices. I'm going to cast the net a bit wider than that, but I'll try and focus in on the dry eye a bit and the keratoconus, which we'll get to eventually. I'll introduce you to my colleagues. Then we'll go through a bit of microbial keratitis, lumps and bumps. Actually, there's a bit of ocular allergy in there. I need to update that. Cataracts, briefly, transplants, keratoconus, I said as well, didn't I? And some dry eyes. So that's me on the left. Then there's Prof. David O'Brat. So many of you will know him. He's been at St Thomas's longer than either me or Manny, who joined more recently. And we're all leading on the cornea and anterior segment side. We have a great team of optometrists, and we recently recruited a few to the cause. So we're quite nicely organized for managing all of these patients now. We did have a cataract fellow, but because the cataract sort of numbers dwindled a bit, they're now on the upside again. We had to sacrifice them, but we've got the optometrists instead, so it's all worked out quite nicely, actually. And we've got a corneal fellow as well, so Bayer, who currently works with us and is shortly going to join Moorfields in August. Right, so microbial keratitis. I'm going to start with a fairly standard case that you might come across. 18-year-old female, contact lens wearer, fell asleep with her contacts in and comes to you with pain and redness in the eye. Now, if it looks like this, I don't think anyone's going to be in any doubt that this patient needs to go straight to hospital and be seen in eye casualty and sorted out. But you might see something like this and think, okay, this is well within my ambit. I'm going to have a crack at it. And I would try and dissuade you from that because even though these ulcers can be small, they can rapidly get out of control if they're bacterial. And even in eye casualty now, we have a pretty low bar for scraping, I have to say. So we will take samples from this or encourage that amongst the juniors, and then hopefully get a result. Although, you know, less than 50% of the time we will get a growth on any scrape. And we treat all diagnoses as provisional. They all get intensive topical antibiotic treatment at the outset before we consider other possible causes. And we will try and treat any precipitating causes such as any surface disease, neurotrophic keratopathy and things like that, if we think it's not just the contact lens and they're not a contact lens wearer at all. Why do we not want these treated in the community? Because Pseudomonas, which constitutes about 5 to 24% of all microbial keratitis cases, depending on which literature you read, and certainly constitutes about 70% of all contact lens associated microbial keratitis cases, is one of the leading causes, obviously. And we can also see polymicrobial causes in about 10% of patients. And why does this matter? Because chloramphenicol, which is available in the community, is not effective against Pseudomonas. And every so often we'll see a patient popping in, not necessarily via the optoms, who has been using chloramphenicol to no effect, and their ulcer has got worse when it needn't have if they presented earlier. If things can follow a fairly convoluted course if they don't respond the way we expect them to, but generally speaking, as I've mentioned, we are going to treat these cases with intensive topical antibiotic therapy, broad spectrum, And usually it will be a quinolone such as moxifloxacin, which has broad sort of bacterial cover for gram-positive, gram-negative bacteria. Occasionally we'll throw gentamicin and cefuroxime at these sorts of eyes if they're severe, but the gentamicin is a bit toxic for the ocular surface, and so we try to avoid that for most cases if we can. And generally we're talking about hourly, day and night for 2 days, and then hourly for a further 3 days. And sometimes you'll see a bit of worsening as bacteria are all killed off and get a bit of inflammation resulting from that. So it's not unusual to see a bit of worsening 48 hours down the line. I don't know if I should go into this in too much detail. Generally, bacterial infections are very rapidly progressing. You'll see some ulceration of the epithelium very often, and sort of with Pseudomonas is fairly classic sort of Pseudomonas ulcer with mucopurulent sort of discharge, just a slothy looking surface and corneal edema, and you might see thickening of the corneal folds and desmase membrane. They tend to get a lot of inflammation, so you might see some conjunctival chemosis and hyperemia. And it can be difficult to tell what the cause is from clinical appearances, but it's not generally that the feeling is that if you see sort of things like serrated margins, satellite lesions and things, you should be thinking chalky sort of ulcers, that's the possibility of fungus needs to enter your mind, although it should always be there in the background. You should always be considering that as a possibility, even in a contact lens wearer. HSV, oh, I don't know what's going on in the background there, you have to ignore all that. HSV, particularly in a contact lens wearer, is a diagnosis of exclusion. Okay, so very rarely do we see people getting into big trouble with HSV, but we do see contact lens wearers who've been misdiagnosed as HSK because the appearances were a bit misleading and treated with a bit of steroid, which is obviously a no-no, without managing the infection first, and that can lead to real problems. So if you think that a patient might have HSV, then in any case, it goes to eye casualty, and hopefully the juniors will involve us if they're worried that the diagnosis is not what they usually think it might be. And acanthamoeba, I've got a few of these on my books at the moment. This is a nasty organism, and it can wreak real havoc and be difficult to manage. Generally, it's fairly sort of indolent. They might get pain and photophobia out of proportion to the signs. And classically, you will get this sort of ground glass appearance to the epithelium that doesn't raise much alarm. But if it's not managed appropriately, it gets a grip. You do have a window of opportunity. You know, if you start treatment within 3 to 4 weeks of the diagnosis, then usually the outcome can be good. But I've got one lady who's quite young who've just had to perform a lamellar keratoplasty on a year down the line because the cornea went completely opaque. She got a white cataract because of all the inflammation. The iris is sort of bunched up in the angle because of all the inflammation as well. So she's needed a tube on top of the lamellar keratoplasty. And I've got another lady who is a contact lens wearer as well. And she developed the condition in pregnancy. And actually the cornea remained pretty clear until she gave birth. And after that, the immune system really kicked into action. And she's now got a ring infiltrate, which I'm trying to manage. And I've had to immunosuppress her for that. So, have a low index of suspicion for things like this in contact lens wearers. I don't want to get into this in too much detail. A lot of it is fairly common sense. All I would say is that be aware that ocular surface disease, so people with allergies or things like that are at higher risk of developing infection in their corneas. So any contact lens wearer with an acute red eye, I would say send to eye casualty. And even if it's not an infection, we've managed it appropriately. Keratoconus. So again, it's quite a big subject. I imagine this is fairly sort of common. So you might see a 21-year-old man suspect the keratoconus. They've got reduced uncorrected visual acuities. It's corrects up a bit on refraction. You can see the sill is quite high here on the right. And we'll often see referrals that look a lot like this. And I think Lavina has one which is also collected. No significant history otherwise. A slit lamp examination unremarkable. And you might see this on the topography. So it's very clearly keratoconus, and we can look at various indices to confirm the diagnosis, particularly in the other eye as well. We may see changes in the posterior cornea that give rise to the diagnosis on that side, even though it appears normal. So we usually consider this to be a bilateral disease. And obviously, the question for us when we see these in clinic for the first time is, do they need cross-linking? And it can be a bit difficult to make that decision if we don't have the information that we require. And basically, what we want to know is, I mean, ideally, you might have some historical data derived from the Pentacam or a similar OCT or topography machine that allows you to see that the Kmax or the K1 or K2 have increased by a diopter. Or you may take into account other factors such as the corneal thickness in making a decision as to whether there's been progression or not. But certainly we will set the bar lower for those who are younger. So there's a high risk of progression in those under 18 that we would want to take into account. So if you see someone in that age range, then ideally we should see them urgently, I would say, because they can progress within 6 months quite rapidly. Other inclusion criteria we might take into account is a history of progression in the referral letter that's based on either serial topography or loss of corrected vision. So if the patient says, yes, I've definitely lost vision in my glasses, and there's some evidence of that, hopefully, then we will act to cross-link. And it's certainly, if there's history of previous LASIK, then the bar is lowered. If they've got an inflamed surface, or there's a very thin cornea, and even if it's below that, we might consider it, then we will delay cross-linking until the surface disease, for example, is controlled. But the more data, the better. So I would say sometimes we see these letters, and it's either I'm not looking carefully enough, which is perfectly possible, or the letter is not dated. So we will have a refraction. You'll have done a lovely job of documenting your findings, but we don't know when that was done. And it might have been a year ago, given the waiting lists, or it might have been a few months, and that kind of makes a difference sometimes. So I would encourage you to try and date your letters if you can. Please include any historical refractions if you do have them, because again, that's helpful in determining whether there's been progression or not. Some of the patients have been sort of steered through independent providers on their way to us. And I have to say, they haven't added much to the management, because they will literally just rubber stamp what you've written and then send them on to us, because they don't have the equipment to confirm a diagnosis or confirm progression, and they can't treat either, at least not at the moment. So it can delay things unnecessarily. If they're a contact lens wearer, you might want to ask them to keep their lenses out for a week before they attend us, but it's not essential, I would say. And as I've said already, younger patients merit more urgent referral, I would say. So you can email us or just put that in the referral letter. We will see most of the keratoconus patients that had cataract will come to us. So if you see cataracts in patients with keratoconus, then we'd be interested in those, because there is a risk of a hyperopic refractive surprise if we don't take into account the corneal shape. And we'd like to establish some stability as well, although that's usually not a problem given the age range of patients having cataract surgery. We do provide an extended preoperative counselling to ensure the patient's aware of the risk of refractive surprise contact. So we're also keen to ensure that patients, given the option of a toric lens, if they're suitable candidates for it, not if they're RGP wearers and they intend to continue wearing their lenses. And we might, under certain circumstances, consider rehabilitating the cornea and undertaking a deep anterior lamellar keratoplasty if indicated prior to doing any cataract surgery. Allergic eye disease. Right, this is a big, big topic. And I know there are a few pediatric cases in Bavina's presentation, or the cases that she's going to run through. The thing to remember about allergic eye disease is pretty common, okay? So most of the common stuff is mild. So I don't see that. I see a lot of the severe stuff, and the severe stuff can be blinding. I have to say the pediatric patients, fortunately, go through the pediatric service, so I don't tend to see them very often, unless there have been real problems. For the most part, the mild and common stuff is the perennial allergic conjunctivitis, so all throughout the year, or seasonal allergic conjunctivitis that I'm sure you guys see a lot of. Often there's a family history or a history of allergy generally, say atopic dermatitis, eczema, and things like that. Children can get what's called vernal keratoconjunctivitis. So you'll see things like limbal, elevated nodules around the limbus, sort of lymphatic tissue that's sort of become activated. Those are called Trantis dots. And you might see a mixture of limbal inflammation, palpable, or a mixture of all three. And the vernal tends to end up in the hospitalized service because it can be quite severe and difficult to manage. Then in adults, we'll see things like atopic keratoconjunctivitis, which is at the more severe end of the spectrum. Very frequently, we'll see atopic dermatitis in conjunction with that, and it's worth bearing in mind that that is commonly associated with ocular surface disease, as is all of this stuff. So you'll see allergic conjunctivitis, blepharitis, and keratitis in about almost half of patients or more who have eczema. And I bear the brunt of that because a lot of it comes through St. John's Institute of Dermatology, actually, and you might not ever encounter it. That said, it's surprising how many patients with eczema managed at St. John's Institute of Dermatology guys had not come into contact with either an optometrist or an ophthalmologist before. And some of them do have keratoconus. So I have suggested that there probably is an argument for all of those patients at least seeing an optometrist in the community, if not me and the team over at St. Thomas's. And then there's things like contact lens associated papillary conjunctivitis and so forth, which you guys will see a lot of, I imagine. I see less of it. Common symptoms. So the cardinal symptom with allergic eye disease is itching. Okay, so if your patient has itching, then it's usually a sign that they have allergy. So it's worth asking very specifically about that. They may also complain of foreign body sensation. They may also have stringy mucus discharge from the eye. That would normally indicate more severe disease. And they may complain of extreme discomfort, again, in cases which are more severe. It's worth inquiring after changes in vision and changes in glasses prescriptions, because as we'll see, keratoconus is more common in this cohort of patients. And common clinical features as well, you'll be familiar with this. A bit of hyperemia, papillae, and sometimes very gross sort of cobblestone papillae as well. So as I mentioned, eczema is associated with this. You don't see it in all patients with eczema, but certainly a great many. Conjunctival inflammation mentioned, blepharitis. We can often look at this like this in patients who've never even seen an ophthalmologist or an optometrist, it turns out. They can have really bad eczema and never, oh, sorry, this is kind of on autopilot, this presentation is suddenly. So it's not unusual to see that sometimes in the hospitalized service. And then, of course, the conjunctival papillae. Some of these patients will have such tight lids that they have leg ophthalmos. So you may see signs associated with that. Sometimes the punctate keratopathy has been grinding on for a long time and they have really awful looking epithelium. And again, if it's been going on for a while, you'll start to see reticular scarring and shortening of the fornix in these patients. It's more obvious on this side, isn't it? So that's pretty active disease. It needs to be brought under control. Sight-threatening complications. So these patients can really run into trouble with things like scarring. As you've seen, they can get shield ulcers, so acute, with usually associated with severe papillopathy in the palpable conjunctiva. They'll get an accumulation of immune cell infiltrate and an ulcer developing, and again, that's sight-threatening, needs to be managed with aggressive intensive topical steroid. Microbial keratitis, as I mentioned earlier, is more common in these patients, and similarly HSVs, as the dermatologist will tell you, because many of the eczema patients are on prophylactic acyclovir already for other forms of HSV infection. They can get glaucoma if you're not careful about how you're using your steroids, and cataract. And keratoconus is also more common in this patient group. How do we manage them? Well, obviously, topical lubricants are the mainstay for symptom relief. We will use combined mast cell stabilizers and antihistamines such as opatanol, and it's not uncommon for them to already be on fexofenadine from the dermatologist if they're under their care. And these are what are called mast cell stabilizers, which have kind of been superseded by these combination treatments. And then if they're really really bad shape, then we'll throw some dexamethasone or prednisolone acetate, but usually they're dexa-free, so preservative-free dexamethasone intensively, and then hopefully after that they don't need much more than fluorometholone if things get out of control. Just bear in mind the effects of steroids. It'd be unusual for the patients to end up in the community, but it's possible, I suppose, and it's just worth noting that that can cause problems. If they're needing lots of steroids, oh wow, that's weird. Hold on a sec. Oh, it stopped now. Oh, odd. Okay, is anyone getting that? That's like
you can see the slide, if that's okay.
Sorry, say that again.
We can see your slide, okay.
Oh, okay, all right. Sorry, I heard myself talking there, which I don't think it was in my head. Anyway, if they're needing a lot of steroid or they're getting frequent exacerbations, then we will start calcineurin inhibitors. So you'll be familiar with these, hopefully. The most commonly prescribed is probably Icabis, which is cyclosporin 0.1%. It's expensive, it stings a bit. Very often the GPs will push back a bit, either because they can't, it's not on their formulary, or they're a bit nervous about prescribing it. That can be difficult because compliance is not always great, but it is worth starting nevertheless. For children, there's the equivalent called Vercasia. And I would say generally it's better tolerated if they're already on some steroid, just to, if that's kicking in, then it gives them a bit of time for this to work and they'll tolerate it a bit better. For those patients where the cyclosporin is causing problems, usually because of compliance issues, then I'll start them on topical tacrolimus. Has a higher potency than the cyclosporin. It's widely prescribed for eczema control. So very often these patients are already on it for their skin. And if they tolerate it, then they'll probably, for the skin, they'll probably tolerate it for the lid margins. And even though it's unlicensed for use in the eye, I will suggest they apply a little bit to the lid margins daily, maybe to begin with. But if they're finding that this sort of burning sensation that can happen on application is a problem, then it can be reduced to maybe a couple of times a week, and that may be enough to keep things under control. And they get a big tube of this stuff. They don't have to keep going back to the GP for more, so it's quite helpful. Oh, sorry, I know what this is. Give me a second. I've got to switch off. It's because I've got some old slides. Just get rid of that. I'm going to show you this slide, and then hopefully it's just this slide that's got some commentary on it. So you may be familiar with this drug. It's called dupilumab. It's really been a game changer for the management of severe eczema, moderate to severe eczema. That means a lot of patients who've been on more horrendous drugs, immunosuppression for their eczema, have been directed down the route of having this, which is they can inject themselves subcutaneously, usually fortnightly, and it blocks certain immune pathway. So for those of you who know your immunology, interleukin 4 and 13, and it's really great for switching off your eczema. Unfortunately, in about 20% of patients or so, about 20 to 30% of patients, they'll get really red eyes, and it disrupts the production of mucin, we think, by the goblet cells in the conj. And so they get really horrible sort of foreign body sensation, and it's unpleasant, and as I say, really red eyes as well. It's not really a sight-threatening side effect, but the real battle is to try and control it such that the patient can continue on the dupilumab therapy, because there are not a lot of alternatives. There's a similar drug for which there's evidence that it might be less inflammatory for the eyes, but otherwise they're on other things. They'll have to go on what we call it escapes me, but they go on other drugs, and not the side effect profile is not as great. So for the most part, they all stay on this drug, and they're really happy with it. It's just the eyes that cause problems. But I'm saying that just so you're aware of it. We'll usually manage it just as we manage the allergic eye disease, so topical steroids and a steroid-sparing topical medication such as the tacrolimus or the Ibicvis. Lumps and bumps, we occasionally see these referred to us by our optometrist colleagues in the community. So pterygium most commonly. Not surprisingly, we have high numbers of immigrants from equatorial regions. So see loads of these, loads. The bottom line is, if they don't want surgery, then there's probably not much point referring them, unless they have atypical features or it's affecting their central cornea. So if it's driving a lot of change in their refraction, they're getting a lot of astigmatism, then obviously maybe we should just get rid of it. If this thing is encroaching on the center of the cornea, then when we remove it, it can induce a bit of scarring in this area, and we want to avoid that. So there is an argument for getting rid of it earlier. But a lot of them kind of, well, not a lot, that's a bit unfair. A lot of patients will, some patients will pitch up, and then we'll offer them surgery, and they'll say they don't want it, which is fair enough. Some say, quite a few will say, can I come back in a year? And we'll have to have a little to and fro about the merits of that, because it is like watching paint dry, a pterygium getting worse, and you really don't want a clinic full of patients who are debating whether to have pterygium surgery or not. So we don't really want to watch these if we can help it. Right, let me go back into this. Right, conjunctiva, non-urgent referral. So not many of these come our way, but occasionally we'll see patients who've got a bit of conjunctival pigmentation that seems to be misbehaving. Most of these turn out to be conjunctival nevi. If you see a change in sort of new pigment on the ocular surface in one eye, and usually in a light-skinned individual, then that might need biopsying, because it could be something called primary acquired melanosis. And if that shows some changes in the cells that could predispose to cancerous change, then we may keep them on our books, or refer as appropriate. If they don't have those changes, then it's reasonable, if the area is fairly small or not very extensive, to send them back into the community for monitoring. Then there are other rarer things like conjunctival ocular melanosis, which I won't go into. As I say, nevi usually have these kind of cystic changes, variable kind of pigments. Only the bulbar conj is usually affected, and they don't have any funny feeder vessels or anything odd about them. You don't tend to see any growth after the second decade of life, but they might darken a bit in puberty and pregnancy. So you might see that occasionally. And we also see the odd conjunctival papilloma coming our way. These can be roughly divided into squamous cell papillomas and limbal papillomas. The squamous cell papillomas occur in younger patients. They have the sort of classical cauliflower-like appearance. It can be bilateral or multiple, and they're obviously associated with human papilloma virus infection. Usually, if you might see them in the inferior fornix, about quarter in the affect the caruncle, and they can recur following excision and cryo. But yes, we'll manage those. The limbal papillomas tend to affect older patients, and again, we see those as well. So I would suggest advise of possible diagnosis if you see one of these, and the importance of attending and not cancelling, and what to do if they don't receive an appointment. And ideally, if you can, email us with any photos. Sometimes we get sent these iris freckles and nevi. For the most part, you don't need to refer complexion-associated conjunctival melanosis. That's common in dark, it's a benign condition. Darkly pigmented individuals often have a lot of conjunctival pigmentation as well. And you'll see that it's sort of flat, non-cystic, often present around the limbus. Can cover the conj extensively and increase in size with age. And unlike primary acquired melanosis and nevi, is usually bilateral. Freckles in the iris, we've all seen these every day. These are sort of tiny dark brown flecks on the surface. Harmless, don't normally develop into anything more serious. And similarly, iris nevi, they're just a bit more prominent, a bit larger, and they tend to involve the iris stroma. And they can grow a bit with time, but usually, again, they're benign. Iris cysts, I saw one of these the other day. This is really what we do. We'll have a good look on the slit lamp, do some gonio with 3-mirror, some ultrasound, and probably an OCT, anterior segment OCT, which is what you can see here, really. And that usually helps us determine whether it's a cyst or not. And if it is, then it's usually something we can observe, unless the thing is really big. And sometimes they can be, and they can affect the drainage from the angle and need to be treated. If they're very stable and small, then they can be managed fairly conservatively. Occasionally, we'll see something like this, and we'll forward it to Moorfields Oncology for further management. So iris and ciliary body melanomas, they're pretty rare. Constitute about 10% of uveal melanomas, with the rest being choroidal. Almost all the iris melanomas are inferior, and they can sort of spread around the angle a bit and cause problems with glaucoma. Ciliary body melanomas may be less obvious, but they can be sort of dome-shaped or some circumferential. And they'll be sort of in this area, so you might see some what we call sentinel vessels, so the episcleral vasculature tends to dilate a bit. If you see something like this, then the best thing to do is try and be methodical about it. Try and describe the site as best you can, which quadrants are affected, any circumferential spread, size of it, any anterior, posterior extension, and sort of whether it looks solid, cystic, or multicystic. Sometimes transillumination is helpful. Any distortion of the anatomies, the pupil margin, things like that. The color, the vascularity, and any seeding. Things like other things you might find, things like glaucoma, hyphema, dilated episcleral vessels, as I mentioned, tropian uvei and pupil peaking, and iris cysts and band keratopathy as well. So any suspected conjunctival malignancy, refer it. If you mentioned the primary acquired melanosis, melanoma, as I said, is very rare in the conj as well. Non-bulbar conj, if that's affected, then it's more likely. Growth after teenage years, again, more likely. And if it's big, if it's greater than 5 millimeters, or there are things like feeder vessels, diffuse pigmentation, or the patient's older, then again, it's more likely. But again, most of the time, these things turn out not to be what we worry about. So I won't go into the details. If you suspect any uveal melanoma, again, refer urgently. And same goes for any melanocytic iris tumors, things like that. If they're greater than 3 millimeters in diameter, 1 millimeter elevation, then we'd be more interested. So if you think this is an iris nevus and it's kind of on the large side and it's elevated, then obviously we want to see it. We have to field these, even though we're not sort of experts in ocular oncology. And that's just what the Royal College guidance states. So we will see them and assess them, and if necessary, we'll forward those referrals to Moorfields Oncology, which is our local centre. If it's obviously going to delay things a bit, if the patient's waiting for an appointment with us when they could have been referred from us to Moorfields and seen much faster. So just be aware that there's potential for delay in cock-ups here, and follow the 2-week suspected cancer pathway, give the patient fast-track information. Let me just get this out of the way. There's a fast-track information sheet leaflet that you can print out, and instruct the patient what to do if they don't get the appointment, and make sure that they attend. That's all I will say on that subject. Some of these things can be monitored safely in the community, but if you're unsure about anything, then send it to us and we'll make a decision for you.
Mr. Robbie, is it possible that I give you a couple minutes more and then we move on to questions?
Okay.
Thanks.
I should just say, sometimes chalazions end up in our clinic. We don't really want to see chalazions if we can help it. They should go to the cyst clinic. They'll be better managed there and more rapidly. So that's just to say something about chalazions. Any lumps and bumps affecting the lids, probably best to go to the adnexal service. Dry eye. Well, this is a really big subject, and we could spend all day, if not all week, on it, and I really don't want to. It's best to try and be methodical about this stuff. Broadly, you can subdivide patients into asymptomatic and symptomatic, and then those with signs and those without. And then depending on the severity of any disease, you'll manage it accordingly. It can be tricky to manage these patients. And you probably see way more than I do. I tend to see patients once all the options have been exhausted. But even I have to sometimes sit back and think a bit about what's going on. Again, you can broadly divide these patients into aqueous deficient and evaporative dry eye. We tend to see obviously a bit more of the Sjogren's syndrome cases, and we'll manage those accordingly, plugs, serum drops, and things like that. And then there's sort of non-Sjogren dry eye as well, lacrimal deficiency, lacrimal gland obstruction, which we'll see in some patients with severe inflammation. And then the evaporative you'll be familiar with, things like meibomian gland dysfunction and contact lens wearers, obviously, and then the ocular surface disease, things like allergy. I don't want to spend too long on that, but it's obvious that if patients have severe uncontrolled dry eye disease, then they can get into trouble with all sorts of surface disease problems, sort of conjunctivalization of the cornea, filamentary keratitis here. They can be difficult to manage and sometimes need a multidisciplinary approach depending on the cause. This is another sort of Dew's kind of algorithm, which is quite helpful. And the bit that I kind of want to draw your attention to here is the questions. Okay, so kind of forget about this as ophthalmologists and probably optometrists. I won't speak for you. But history taking a bit of a dying art these days, and it's really important to take one, a good one. So ask, how severe is the eye discomfort? Ask them, do they have any mouth dryness or enlarged glands? Because that might suggest something like Sjogren's syndrome. How long have they had their symptoms? Was there any event that triggered them? Is their vision affected and does it clear on blinking? Are the symptoms or any redness worse in one eye compared with the other. So this sort of asymmetricality would be a bit odd. Do the eyes itch? So things like allergy, any crusting, discharge from the eyes. Do they wear contact lenses? And have they got any other health issues that we ought to know about? So those are fairly broad sort of questions that are useful to ask. There are obviously many risk factors for tear dysfunction. I won't go into them in too much detail, but you'll be aware of them all, I'm sure. For those, if the cause is not immediately suggested by the history, then you're going to have to do a detailed examination. And obviously, we're working methodically through examining the lashes. I have to say, we don't make the diagnosis of Demodex infestation much in a hospital eye service, but it seems to be more commonly diagnosed in refractive surgery centres. Probably, I guess, because they're more sort of invested in optimizing ocular surfaces pre-op. But it can be tricky to diagnose. You really got to really look for sort of collarettes and things that come with that, and sort of cylindrical attachment to the base of the lashes. Eyelid, we'll look at the palpable conjunctiva, so evert the lid, look at the bulbar conjunctiva very carefully, look for any corneal ulceration or staining, and the anterior chamber very carefully. Assess the skin of the lids in normal light. Yeah, and you're going to use some preserved fluorescein to look at the tear meniscus and the corneal surface. This is all fairly bread and butter stuff, so I'm assuming that you all know this. I don't want to spend too much time on it because Bavina is probably straining at the leash. So we're going to skip through this and we'll come back to it if I need to, okay? Because it's quite a lot of this stuff. Do you want me to stop, Bavina?
Yes, would you mind if
okay.
we need to crack on with the cases?
Right, let's do that then.
Into a fully...
Given most of the cases are dry eye cases, I feel like I should have probably started with this, but never mind. Okay.
If you
Let's
are
crack on.
happy to share some of your slides with the participants, I can distribute them. If
that's fine. Yeah.
Whichever works for you. Yes, perfect.
Yeah.
Thank you very much. We do have a couple of questions. So first question was for you, Mr. Robbie, from one of the participants. What type of cataracts would you most likely expect to see if the patient was keratoconic?
I can't say that there's a particular flavor of cataract that I would expect to see. It kind of depends. So if it's not unusual to see, obviously keratoconus, we tend to see more young patients with keratoconus, okay? Because a lot of the patients who are older have stabilized a long time ago, and either they never come into the hospital eye service, or they only present when they have cataract, and when they do have cataracts, usually the standard variety, nuclear sclerotic cataract or a cortical cataract. So I would say when it gets interesting is if the patient's very high myope, then they might develop a nuclear sclerotic cataract a bit earlier in life. So that might be one situation. And there are a few young patients who develop posterior subcapsular cataracts because of use of steroids, either systemic or topical steroids, as a result of their allergic eye disease. So that's probably about all I can say on that subject.
Thank you. That was most interesting. The second question, and probably the last question, so we can move on to the cases. Discussed a lot of anterior eye diseases aside from just the cornea. And when we refer in as practitioners, when we feel the need to refer into clinic, our options for anterior eye is relatively limited from the ERS system. So things like conjunctival ? Or iris ? Would we be better off sending it to cornea? Because actually externally we have oculoplastics, cornea, and that's pretty much it at the moment that we can access.
Yeah, I don't think that the oculoplastics team are going to be terribly enamored if they're having to see iris levi and things like that. They even I have to remind myself how to manage these things occasionally, and they definitely will. So I don't think I would send those their way. But yeah, we're very happy to take on this stuff. We're not always fully equipped to manage it. So Moorfields Oncology, for example, will have access to 5FU drops and things like that, which will melt away conjunctival intraepithelial neoplasia and stuff like that, which we don't have. And it's probably better that they're sort of seen ultimately. Anyone with sort of cancerous changes seen in a specialist service, because it's there's a lot of firefighting in our department at the moment. The waiting lists are high. There's a lot of shifting in the numbers in clinics a lot, so that can affect follow-ups, and we don't want any delays with those sorts of patients.
Yeah. So speaking of waiting lists, I'll quickly move on. But speaking of waiting lists, our expectations to let the patients know if we are referring for something we consider to be relatively routine, but they want a consult with cornea team. Are we looking at 6 months to 12 months? Are we looking for longer, less than that? For routine.
That's a good question. I don't know what our waiting list is for new patients at the moment for just a routine new. It's probably about 6 months, I suspect. Yeah. So yeah, they need to be told that there will be a delay. It's probably not that long, actually. I'm seeing a few sort of filtering through after 3 months or so. It's not too bad, I don't think. But so we are cracking through them. Yeah, but I think try and make, if you think there's something urgent, then there's probably not much in between. It's either routine or it's going to be urgent. And we'll try and make exceptions for urgent patients. I certainly do for the dermatologists who sort of keep me busy with their dupilumab patients. So we can squeeze people in if we have to. Just email us.
Thank you so much. Okay, I'm going to click stop recording.